very lucky to welcome on PGY2 emergency medicine pharmacy resident Sean Chi as our next clinical Pearl presenter. Now, Sean is just finishing his residency at Inova Fairfax Medical Campus in Virginia. Sean, welcome. How are you doing today, man?
Hey, I'm doing great. Really excited to be here, Nick.
Me too. The pleasure is all mine. Now we're in the mid June, so we're starting to hobbies are starting to come back and things. So, what's something you do fun? Something to get away from pharmacy and medicine in general?
Yeah, one of my biggest hobbies outside of pharmacy is probably disc golf. I started playing a lot this year and a couple years prior, so that's been really a lot of fun to help me get away from pharmacy.
So there's probably some golfers, and there's probably people that play frisbee, but I bet there's not tons of people who bring the two intertwined. I love it. Shout out Anthony Hawkins. He loves disc golf as well. What's your distance? Because one of the things you're like, I can throw it farther than a football field. So now I'm like, all right, now my mind's going. So what's the if you're really throwing back and you're doing like a one time, how far you think you could launch that bad boy?
Yeah, probably the furthest I've thrown is just under 500 feet. So it's they can go pretty far. So it's a lot of fun getting to just launch them.
All right, follow up. Do you have like a lucky color? Do you have like a lucky
Ooh.
disc? How does that work? Or is it nope, it's all the muscle memory and the flick?
That's a great question. I don't really have a lucky color or lucky disc, just whatever I have with me. I've been playing for a while, so a lot of it's just muscle memory and just let it rip.
That's how you know you're good. You don't need any. You're like, yep, whatever we got, I'll make it work. All right. The real reason we are here. So once ROSC is achieved in our patients undergoing cardiac arrest, new problems and goals become unlocked for the medical team. Now, Sean, let's highlight how we not only treat, but manage and recognize one fairly common problem in our cardiac arrest patient population. So the floor is yours.
Awesome. I appreciate that introduction, Nick. So, hey, everybody, I'm really excited today to talk about what I think is a super interesting topic, like Nick has discussed, post-ROSC vasopressors. So, to start off, I really want to paint a picture and present a patient scenario that we oftentimes see in our emergency department. So, imagine you're working a shift in the emergency room and you receive an overhead page for a cardiac arrest. You and some team members arrive to the room and find out that the patient went into VFib and compressions were started. As the pharmacist, you join the ACLS response and take over the medications in the code card. After 2 rounds of CPR and ACLS, at the next pulse check, you find out that the patient does have a pulse and the monitor reads a sinus rhythm. So now our priorities shift away from our ACLS algorithm to our post-arrest care algorithm, which starts with the ABCs. As we move through the ABCs, we first secure an airway, and then we get a blood pressure. And on the monitor, the first blood pressure that comes up reads 70 over 38 with a MAP of 49. Now, this leads me to two big questions that I want to discuss with today's talk. What do we need to do about this? And how do we do that? So before we can answer this question, I do want to provide a little bit of background. When we talk about cardiac arrest, we do recognize that the overall rates of survival to hospital discharge are pretty low. The 2025 AHA heart disease statistics report rates that average anywhere from 7 to 24%, depending on several factors. These factors can include out of hospital versus in hospital cardiac arrest, the use of bystander CPR, the patient's downtime, the initial rhythm, and much, much more. And while overall survival is a positive outcome, the outcome that is likely more clinically impactful is survival with good neurological functional status. And as expected, this survival rate with good neurological function status is lower than overall survival. One of the key factors in preserving neurological outcomes is to make sure that we're able to perfuse the brain during and after cardiac arrest. And especially in this after cardiac arrest phase, in this post-ROSC phase, this is often complicated and presents a challenge due to hemodynamic instability from a mixed shock picture. This mixed shock picture, or post-ROSC shock, as many people call it, occurs in over 50% of patients and is composed of both a mix of cardiogenic shock due to post-arrest myocardial injury, myocardial stunning, and a distributive shock due to inflammation and vasoplegia from ischemia reperfusion syndrome. Like we mentioned before, the big goal with managing this post-ROSC shock is to preserve cerebral perfusion to prevent brain tissue injury and maintain good neurological function. So there are several guidelines out there from various groups, such as the American Heart Association, the Neurocritical Care Society, International Consensus on Cardiopulmonary Resuscitation, and European Resuscitation Council. All of these guidelines would provide parameters for hemodynamic goals post-ROSC. But within these guidelines, there are some slight differences with recommendations to maintain a MAP anywhere from at least greater than 65 to greater than 80 millimeters of mercury. Now, interestingly, it's important to remember that these recommendations are actually largely extrapolated from what we know about septic shock and cerebral perfusion, as well as animal models as well. But despite this and the minor differences in these hemodynamic goals between the guidelines, they do all agree on one thing, and that is to avoid hypotension in these post-ROS patients. So while these guidelines do emphasize this recommendation, they unfortunately do not provide additional guidance on the preferred method of achieving this goal and do not comment on a preferred vasopressor. So now we know what we need to do about post-ROS shock, but to answer how, we need to dive into some primary literature and talk more about vasopressors. So when discussing vasopressors, the main ones I do want to focus on are epinephrine and norepinephrine, but we will touch on dopamine briefly as well because it is out there and we need to know a little information about it. So between these agents, there are differences within their pharmacology and medication profiles that I do want to point out. We know that epinephrine works as an alpha and beta agonist with a dose-dependent response, but generally speaking, a higher affinity for beta receptors over our alpha receptors. These beta receptors are located in the heart and contribute to inotropy and chronotropy, which subsequently also causes an increase in myocardial oxygen demand. Epinephrine can also be associated with lactic acidosis and tachyarrhythmias compared to our other vasopressors. Norepinephrine, on the other hand, also works on the alpha and beta receptors, but has a much higher affinity for the alpha receptors. These alpha receptors are located peripherally and are primarily responsible for vasoconstriction. And we know that in patients with septic shock, norepinephrine is the first-line vasopressor due to its mechanism and benefit in this distributive shock picture. And lastly, to briefly talk about dopamine, we know that it also possesses dose-dependent receptor activity for our beta receptors at lower doses, alpha receptors at higher doses, in addition to dopamine receptor activity. Historically, several years ago, dopamine was actually considered one of the first-line vasopressors for shock. However, due to literature that's coming out, including the SOAP2 trial, dopamine has actually fallen out of favor by demonstrating higher rates of tachyarrhythmias and increased mortality and cardiogenic shock compared to norepinephrine. Despite this, it may still be available and utilized in certain scenarios, so it's important for us to recognize where its place in therapy might be. There was an international survey conducted on EMS groups that actually reported 18% of these EMS groups that utilized dopamine as their first-line vasopressor for shock. In addition, specifically in post-ROS shock, there was one retrospective study published by Lee and colleagues in 2020 that actually compared dopamine versus norepinephrine for outside of hospital cardiac arrest and found that there was a non-significant trend towards decreased survival with dopamine. Between these two studies, overall, there really is a lack of strong data that supports the use of dopamine in post-ROS shock, and extrapolating data from other shock states, alternative agents such as epinephrine and norepinephrine may be preferred. When we talk more about deciding between epinephrine and norepinephrine, we really need to jump into primary literature and attack this from two angles, efficacy and safety. So in terms of efficacy for this first study here by Weiss and colleagues, I do want to give a big shout out really quick to our pharmacy colleagues here, as this study was pretty much conducted by an all pharmacy crew. This was the comparison of clinical outcomes with initial norepinephrine or epinephrine for hemodynamic support after return of spontaneous circulation. This study was a single center retrospective study looking at outside of hospital cardiac arrest or in emergency cardiac arrest that compared epinephrine, norepinephrine, and interestingly also dopamine. But unfortunately, the dopamine group did end up being excluded due to low volume. But between epinephrine and norepinephrine, Weiss and colleagues found that epinephrine was actually associated with higher occurrences of refractory shock, rearrest, or death in the emergency department. In addition, the epinephrine group also had numerically higher tachyarrhythmias, but that was also not statistically significant. One thing to point out within the study and the baseline characteristics is that the epinephrine group was slightly sicker at baseline, given that they had higher rates of overall rearrest prior to vasopressor initiation. The second trial I want to bring up here was the epinephrine versus norepinephrine in cardiac arrest patients with post-resuscitation shock, conducted by Bogwin and colleagues in 2022. This was a pretty large trial. It was a multi-center study with a population of over 700 patients who presented with outside of hospital cardiac arrest and received epinephrine or norepinephrine to target a MAP of greater than 65. The authors from this trial actually discovered that epinephrine was associated with an increase in mortality and decreased favorable neurological outcomes compared to norepinephrine. Of note, in this study, similar to the previous study, patients who received epinephrine were much sicker at baseline. They had lower rates of shockable rhythms, they had an increased downtime, and overall worse lab markers compared to patients who received norepinephrine. Summarizing the information that we've learned from these studies, really between the two studies, the question of efficacy might lean towards favoring norepinephrine, but it's difficult to make this conclusion for sure because these studies were both retrospective, and it's hard to ascertain if epinephrine made patients worse or if patients received epinephrine because they had a worse prognosis. So looking at this from the other angle, the safety perspective, I want to give another shout out to our pharmacist, Norman and colleagues, who conducted a study looking at the risk of arrhythmia and post-resuscitative shock after out-of-hospital cardiac arrest between epinephrine and norepinephrine. This was a retrospective multi-center cohort study comparing over 200 patients who received either epinephrine or norepinephrine. And the authors actually found that there was overall no significant difference in the rates of tachyarrhythmias. However, when breaking it down to the specific arrhythmias, the epinephrine group actually was associated with higher rates of ventricular fibrillation compared to norepinephrine. Epinephrine was also associated with increased rates of rearrest and in-hospital mortality, which is similar to what we saw in this previous studies mentioned prior. So taking this into consideration about what we already know about the tachyarrhythmias that are associated with epinephrine, from the safety perspective, it does suggest that norepinephrine might be slightly favored for post-ROS shock. So lastly, after we talk about the efficacy and safety between these two agents, we still need to think about one thing, and that is logistics and practicality. Essentially, we need to think about which agent is most readily available and able to be started quickest to prevent the hypotension as emphasized by those guidelines. This involves knowing whether your hospital stocks premixes, whether they're located in your automated dispensing cabinets or your code carts, or if they have to come from the central pharmacy, or if you as the pharmacist need to know how to compound an infusion at bedside. Either way, it's extremely important to know what medication is most readily available, in addition to how to make a bedside infusion just in case it's necessary. And that decision is important in deciding how to which vasopressor to choose for post-ROS shock. So now we've really talked about the main questions surrounding post-ROS shock. What do we need to do and how do we do it? And at the end of the day, there are a few key pearls and key takeaways that I do want to emphasize. Number one being the post-ROS hemodynamic goal. So across the guidelines, there is a consensus of preventing hypotension and targeting a MAP of at least 65 to help maintain cerebral perfusion. Now, this is arguably the most important point in managing post-ROS shock because we want to make sure we preserve that good neurological function as that is a primary clinical outcome of significance. And the second point is how we manage this, and that is through vasopressors. And overall, the choice of vasopressors is less clear. Then the primary literature does suggest that there may be a benefit with norepinephrine over epinephrine. But at the end of the day, the decisions will still come down to patient characteristics in terms of both efficacy and safety. In addition, the practical and logistical considerations may heavily influence this decision. And as the pharmacist, it is very important, and it is our job to really know the availability of the premixes and how to compound an infusion at bedside if needed. And as a strong reminder, if we are compounding one of those infusions at bedside, it's always important to label the medications before we hand it over to the nurse for administration. Lastly, one key point I also want to highlight is that whichever intervention we decide to pursue, it's very important that we make sure we monitor the patient and follow up to reassess if our hemodynamic goals are being met and if further agents are needed. So with that, I really appreciate you listening in today.
Sean, that was awesome. I think that you dive into the literature, and it's funny, a problem that over 50% of our cardiac arrest patients experience is something that it feels like we only really have retrospective evidence to help solve our question. And I thought that was a really good job reviewing a lot of the limited research. Yeah, big shout out all the pharmacists out there: Ryan Feldman, Caitlin Brown, Aaron Vieruszewski, Alicia Matson. Huge shout out to friends of the pod. But when you were looking through this, I think a common scenario that'll happen, right, is you're in the emergency department, they get ROSC, they still have the 3 milligrams of IV epi circulating. So if anything, their pressure is actually high. They're about to go to CT, and then the nurse yells, "Hey, Sean, our map's 55," right? You go to the Pyxis,
Mm-hmm.
of course, whatever you're going to look for is out, right? Guaranteed. So you have one thing in your code cart. Shout out our old school clinicians, the premixed dopamine bag, right? That everyone's familiar with in there. So does it matter more from your research and things? Because there's kind of two things. Does it matter more which drug we use or what their blood pressure is? Because you highlighted the differences between the agents, but if push comes to shove and say it's all we have is our premixed dopamine, should we get that going and just keep our pressure up? Or if it's like, hey, actually using dopamine may not be our best bet. What's our most important principle when managing our post-ROSC hypotension?
Yeah, that's a great question, Nick. I think it's a snare that oftentimes happens fairly often in the ED. So the big point really is to prevent that hypotension. And that's going to be what's emphasized in the guidelines is maintaining that MAP above 65 to help ensure we have that cerebral perfusion to make sure we keep that potential for good neurological outcome. And if all we're left with is the dopamine that's in the code cart, we have to weigh the risks and benefits of that decision on what medication we start. If we know that we can compound an EpiDrip at bedside from what's available in the automated dispensing cabinet, and you're able to do that quickly, that might be a decision point where you talk with the team, see who's available to help, and really decide what's the best option. But regardless, the big goal is to prevent that hypotension. So I want to make sure that whatever decision you make is going to be able to start the medication as quick as possible to make sure that we achieve that potential good neurological function.
What a kind of eye-opening presentation. I didn't really know the how scant the literature was till we started kind of diving into this. And for everyone that says I'm hard on dopamine, look at that. We just gave dopamine a compliment, a bump up. So I can't think of any better way to end this EM clinical pearl than there. Sean, thank you so much for your effort, energy, time, expertise coming into this clinical pearl. And if you want to get in touch with Sean, he has a top tier Instagram handle, Parmesan_cheese. So huge kudos to you on both realms there. But thanks again, Sean. Appreciate it.
I appreciate it. Thank you so much, Nick.